So my name is Matt Harkenreiter. I'm assistant professor of radiation oncology at Loyola, and I specialize in genito-urinary cancers. So this will be our outline for today. I like giving a little background on radiation therapy, and then we'll talk about prostate cancer, both external beam radiation as well as brachytherapy. We'll touch on bladder cancer and testicular seminoma as well. So we'll start with an overview of radiation therapy. And I should say, if there are any questions as we go, just interrupt me. That way we can keep everybody on the same page. So radiation therapy comes in a lot of different forms, essentially whatever particle is coming out of a machine or an element in order to treat cancer. So the most common types are photons, electrons, and protons. So photons are the most common form of radiation therapy. A photon is just a packet of light. So this is, there's the pointer. May remember this from chemistry, physics class. This is Roy G. Biv, what we can see. But all the way on the end, those are X-rays and gamma rays. So X-rays are just generated by a machine, a gamma ray by an element. So these are just massless particles. External beam radiation therapy is also known as teletherapy. It essentially is any treatment of radiation therapy from a distance. So if you're picturing a patient getting treated, patient is lying on a table, there's a treatment machine that goes around the patient and hence delivers the treatment. External beam can include old technologies, which you guys may have heard of, cobalt-60 or orthovoltage in yesteryear. 3D conformal radiation therapy, which I'll talk a little bit about. But more modern techniques called intensity modulated radiation therapy. Stereotactic radiosurgery, or one of the brand names for the machine is called CyberKnife, that you guys may have heard of. All different techniques that fall under the same realm of external beam. So this is a linear accelerator. This is what the machine looks like. It's the most common treatment delivery unit. So essentially we have a source at the end here, and it just generates electrons. The electrons are forced through a magnetic field, so they are accelerated down this tube. They're bent 270 degrees, and then the electrons hit this tungsten target here, and on the other side come those high energy photons. All within the treatment head here, there's big blocks that can shape the beam. So we can kind of shape it into a square, and then before it comes out into a very customized shape in order to conform it for the patient. So here's kind of a unique shape coming out. That is what actually the patient sees. And then here's a non-schematic. This is a picture of one of the newer versions of this linear accelerator. So what I just showed up here is the electron source up here. It gets accelerated through the magnetic field, turned, and then it gets, the photons get customized, the field gets shaped here before it hits the patient. The patient will be lying here, head up there, feet down here. The table can move in any number of directions for different angles. And these two arms on the side let us take pictures, X-rays, or even a CAT scan of the patient before the treatment is delivered. So I'll touch on that a little bit more. That's called image-guided radiation therapy, where we can take images prior to treatment delivery and ensure that our accuracy is as good as possible before initiating treatment with the patient. So brachytherapy involves actual radioactive material. So the linear accelerator generates X-rays through an electron source. Brachytherapy is radioactive material, iodine, cesium, palladium, that decay And by decaying, they then release those X-rays into the tumor or prostate or cervix, wherever we place those. And so brachytherapy means delivering radiation over a short distance by placing those materials inside or near either a tumor or an area at risk. And then the dose of radiation is called gray. It's always singular. And what it means is amount of energy from the X-rays absorbed into the tissue. So it's not a unit of radiation coming out of the machine until it hits the patient and is absorbed into the tissue. So we'll go a little bit more. I'll start with prostate cancer and talk about external beam radiation therapy. We'll do two quick cases to illustrate the points and the different treatments that we have. One definitive, where the radiation is curative without surgery, and then one scenario after the patient has had surgery. So in general, when we're seeing a new prostate cancer patient, these are the risk groups based on the NCCN. So there's a lot of different risk factors with any tumor, and these are the primary risk factors for prostate cancer. The T stage and the clinical stage is just a digital rectal exam, so what you feel on exam. The Gleason score based on the patient's transrectal ultrasound guided biopsy, and then the PSA. And so we could do talks on each one of these categories. But in general, with increasing risk of disease, the treatment intensity also increases. So usually for low-risk patients, they can choose any one option: active surveillance, prostatectomy, external radiation, or brachytherapy. And they all have an excellent chance of being cured. With high risk, the chances of curing go down, and we often will supplement with some hormone therapy with the external beam. Oftentimes patients may need radiation following their prostatectomy, so we treat those patients more aggressively. So a quick case, this was a 73-year-old patient found to have elevated PSA, had a biopsy with low-grade disease and opted for active surveillance. Within the active surveillance protocol, had repeat biopsy. Gleason stayed at 6. Continued monitoring the PSA, which stayed relatively low in the 4 to 6 range. Then the PSA jumped a little bit to 7, subsequently jumped again to 9, and underwent a repeat biopsy that showed Gleason progression, now with 3+4. So this patient would be in the intermediate risk group with a Gleason 7, but definitely a very favorable patient because he doesn't have any of the other risk factors. So this particular patient was counseled and decided to go with external beam radiation therapy. This is what I consented him for. So these are the main side effects that your patients who are getting radiation will see. For acute symptoms, it's usually those that are occurring about during the second half of treatment or the first month or two afterwards. Fatigue, urinary irritative symptoms or obstructive symptoms, so slowed stream, dysuria. They can have some rectal urgency or frequency. It's not usually diarrhea, but it can be. Mild erythema, we really don't see that anymore with more advanced techniques. The skin dose is always quite low. And then sexual side effects of dry ejaculate. Later, all of those side effects, urinary rectal, are about 5% or less. But you can see strictures, increased frequency, some patients with blood per rectum, and very late risk of second malignancies. There's a lot of talk within, I don't know, it's an easy thing for news organizations or whatever to comment on. So it is real. Patients can get second cancers, but it takes decades for them to form. So it kind of depends on each individual patient. And it's uncommon. So like I talked about before, the more modern use of external radiation is IMRT. It's an acronym for intensity modulated radiation therapy. Essentially what we do is continuously, we can shape the beam to customize the treatment for the patient and minimize the dose to the surrounding organs. So there's a dosimetrist who works on the treatment plan, has an algorithm in the computer to try to meet all of the goals, meaning keeping the bladder and rectum dose to certain acceptable levels while maximizing the dose to the prostate, seminal vesicles, pelvic lymph nodes, whatever our target is. What this allows us to do is decrease the dose to the normal tissues, which decreases side effects, and also allows us to deliver increased dose to the prostate, which we know improves the patient's control of their PSA. So when we are treating a patient, we will do a CAT scan, get the patient in the treatment position, and then the doctors will work on the computer to outline the targets, the area that we want to treat. So in this case, the prostate, with a little bit of margin around it. And then we'll outline the rectum and the bladder as well as our organs at risk, what we're trying to spare, femurs as well. And then after the dosimetrist works on the plan, this is what we get. So now we have our doses. Our standard dose is 78 gray, 2 gray per day, so it takes 39 sessions for the treatment, so it's 8 weeks. And we can see that the high dose is conforming to our target in the middle, and our lower doses are still pretty tight within the pelvis, and we can kind of carve dose out of the rectum. So we limit the amount of radiation just to the front part of the rectum that's most proximate to the prostate. Image-guided radiation therapy is often termed with the IMRT. This just means what we do on a daily basis to ensure that every day the treatment is delivered as best it can be. So we can do X-rays on a daily basis. Those arms come out of the machine. We can get a lateral X-ray. So this is from the patient's plan. And then this is on that given day. So we can ensure that the patient's bony landmarks on this lateral X-ray are perfect. So we can look at the pubic symphysis, the hip bones, the sacrum, make sure that it all lines up how we wanted it to. Same thing with an AP X-ray. Those arms, I said, can also do a quick CAT scan. So those arms come around, they take a series of X-rays that get reconstructed into 3D images. It's called a cone beam CT. And we get pictures that look like this. So this is the axial view. It's kind of blown up. So here's the pubic symphysis, right femur, left femur, the bladder, and then the prostate. This is the orange contour is what we outlined on the plan, and this CT is what was acquired on that given day. So we can then move this patient up, down, left, right, a few millimeters to ensure that the prostate on that given day is aligned with how we develop the treatment plan. And that's something that we would be doing daily for each patient's treatment. Another option to line up to the prostate itself is to combine those X-rays from the front and from the side like I showed initially, but with fiducial markers placed within the prostate. So this is as if we were looking at the prostate on its side. Prostate's there, urethra here, bladder, seminal vesicles, and then this is the anterior rectal wall. Is that you can place fiducials through a needle into the prostate. Most commonly is to do 3 of them, 1 at the base, 1 mid, 1 apex, kind of 2 towards either the right or the left, 1 on the other side, so that when you look at both a lateral and an AP X-ray, that you get a good visualization of those. And this can be done either transrectally, like the biopsies, or transperineal, which is like what we do the brachytherapy seeds. So and this is how those X-rays look on a daily basis. So rather than just lining up to the bone doing these x-rays, we have these three markers that represent the location of the prostate, and then we're lining up to the prostate itself on a daily basis. So we'll get an AP x-ray and a lateral and make sure that what we planned lines up with those fiducials on that given day. So this is a little movie taken from the treatment of a patient that outlines what the treatment delivery actually looks like. So this is kind of the representation of the patient, our green cartoon here. And the treatment head is over towards the patient's right. And it's going to be coming anterior around the patient. Yellow is bladder, brown rectum, purple is the prostate with a little bit of margin. But this box here, that represents the treatment head. And all of these are called leaves. This is the beam being shaped and customized for that patient. So we're kind of looking at this video through the eyes of the machine. And of course, the video didn't come over with it. So what the video shows is essentially as the beam, the treatment head is rotating around the patient, those leaves will open and close to treat the prostate. As the beam gets anterior, they're closed more because otherwise it'd be going straight through the bladder. As it comes more laterally, it opens up. As it gets off to the side, it closes because of the hip. As it comes posteriorly, opens again. We don't routinely deliver direct posterior dose because we don't want to go through the rectum. So it's utilizing your angles and continuously delivering radiation through those leaves that are continuously moving to shape the dose for that patient. Yes?
Can you do any size prostate, or is there a kind of dose?
Any size. Yeah.
Really large.
Yep. Yep. No issues with that at all. There are some machines that are kind of customized for what's called radiosurgery, like pinpoint treatment of brain mets. We had an old one. The picture I showed just replaced that machine in our clinic a week ago, where the field was 10 by 10 centimeters. But even then, if you were to treat a prostate, that's plenty big. You wouldn't be able to treat pelvic lymph nodes if you're limited by your field size there, but that would be the only scenario. All of our machines that we currently have, there's no restrictions. It's essentially a 40 by 40 field. So the only time we run into that is if we have to treat the whole femur in a single field, something like that. Yes, sir?
Do you target the entire prostate or just the areas where
Good question. I get that a lot. So we treat the whole prostate for a few reasons. The main one being that prostate cancer by nature tends to be multifocal. You can have right base and left apex. And the biopsy is just a sample of the gland. And I liken it, I get asked that question with brachytherapy a lot too. The surgeons remove the whole prostate. External, we treat the whole thing. With brachytherapy, we treat all of it. But yeah, it's the multifocality that's most worrisome. So I'd hate to have the PSA come back and not, like, okay, is it now on the contralateral side? And now what do I do? So the question is, do we put fiducials in for all of our patients? So right now, I'm more commonly doing the cone beam CT. So we're doing the CAT scan before each treatment as verification of our positioning. But we can. In our clinic, we're waiting for a new system to come through, where we'll be able to place the fiducials, and there's a device in the treatment machine in the room that can detect where those fiducials are. So if the patient passes gas and it's outside of our tolerance, then the treatment is stopped and the patient is realigned. So in a scenario like that, it lets us decrease our margins. So essentially the margins go along with what imaging you're doing on a daily basis, whether you're doing CAT scan or you have the fiducial markers or fiducial markers that can be tracked. Those will continuously get smaller. Any other questions? So that particular case was for a favorable intermediate risk patient. We could talk a lot longer on high risk and various other factors. But the next scenario that you guys probably see a fair amount of is patients who've gone for surgery and either have risk factors for recurrence or who have a rising PSA months or years later. So this particular patient was 70, had a PSA of around 10, and had a truss biopsy that showed primary Gleason 4, secondary 3 as the dominant Gleason pattern. Underwent a robot-assisted radical prostatectomy. The things that I look for on pathology, in addition to the final Gleason, are the margin status, if there's extension outside of the prostate, which they may call extracapsular extension, seminal vesicle involvement, and lymph node status. So this particular patient had a positive margin at the apex of the prostate and extracapsular extension. The other risk factors were negative. And the post-op PSA was undetectable. So the patient was a pathologic T3A with the extracapsular extension. So it's pretty common if that post-op PSA is detectable, that it's any number that's a automatic referral to the radiation oncologist, or if it's detectable and then 2 years or 10 years later, it's rising to refer to the radiation oncologist. But I wanted to present this case because this patient's post-op PSA is undetectable. So it's 0, which is ideal. There's 3 studies that have looked at these patients, and I'm just presenting one. This is the American study from the Southwest Oncology Group. And this has been published a few times. Essentially, they randomized patients who had any one of those, of 3 risk factors: margins, extension outside the capsule, or seminal vesicle involvement. They had any one of those, even with with an undetectable PSA post-op. Half got observation, half got radiation. They were primarily looking at avoidance of distant metastases. So not only the disease coming back, the PSA rising, but looking at the development of mets. And they showed about a 10% improvement at 10 years in development of distant metastases. And so PSA is one thing, that's a number. The patient can still feel great and require no additional treatment, even with a rising PSA. But preventing them from developing distant metastases is a big endpoint, because with that comes hormone therapy, chemotherapy, palliative radiation for bone mets, painful bone mets, a number of other things. So this is really the main endpoint there. In this particular study, they actually showed that patients lived longer, so they had a better chance of being alive 10 and 15 years from their surgery with the addition of radiation. So I mentioned that there were 3 studies that were all similar. The other 2 did not show improvement in their overall survival. So that maybe this study is an outlier, but they all showed that there's an improvement in distant metastases. So I think that's a real and meaningful endpoint. So even with a PSA of 0 for patients with those risk factors, if I see them, I still offer them radiation therapy for that reason.